Hi, and welcome to the Future of Dermatology Podcast. I'm your host, Dr. Faranak Kamangar, board-certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
I'm going to be talking about some therapeutic options for hyperhidrosis, a condition we all see in clinic. And we're all, I think, pretty familiar with the therapeutics as well. Hopefully this will just be a good review with some new updates, and then just kind of going over some things that sometimes we all kind of forget here and there. And no financial disclosures. Hyperhidrosis is a condition we're all pretty used to. It's a pretty easy diagnosis. Most times our patients have made it before they come to see us. We know it's just more sweating than your body needs for the amount of thermoregulatory needs that your body needs. Usually, there's some numbers here, but if you just look at them briefly, usually you should only be able to make a little bit of sweat. Only 5% of your glands are active at a certain time. That's not the case in severe hyperhidrosis. You can have, there's some specific numbers here, but basically you can have a lot of sweating per minute. I have a little beaker down there. You can see how much 40 milliliters is. That's actually a lot of sweating per meter square per minute. So it can just really be debilitating to our patients. The main reason it's hypothesized that these things happen, we know that the eccrine sweat glands are absolutely normal. When you look at the number, microscopically and on pathology, they're completely normal sweat glands. So it's just a problem of the innervation by the sympathetic cholinergic nerve fibers. So it's hypothesized that either the peripheral nerve fibers are just firing too much, or on the other hand, that actually in your brain, you have your emotions, and then you have your thermoregulatory needs. And usually those two things should be in balance. So let's say you're feeling really anxious and you start sweating, but then your body tells you, it's not that hot, so don't sweat that much. So those things should be in tune. And in patients with hyperhidrosis, sometimes the emotion overtakes the thermoregulatory need. So their body isn't telling them that, it's not that hot, stop sweating. So even like a little bit of anxiety can result in this excessive response. And it's not that the patients are hyper emotional. It's just a normal emotion that everyone else has, but they just have this hyper response to it. It's very prevalent. It's thought actually in the US, it's probably underreported. Our numbers are about 4.8%, whereas in other parts of the world, there's much higher numbers. But even here, it's over 15 million individuals. Men and women are equal, except we probably usually see more women because they usually seek more care for it. And it starts actually pretty early on. The highest prevalence is it could start as early as 14, highest prevalence is between 18 to 39. And then it really drops off after 65. So there really could be this regression later on in life. So that might be some good news. We could tell our patients that it may get better. And then of course, there's lots of issues that come up with it. There's a lot of distress in the workplace, just interracial interactions, with the social interactions and dating, all of that. Just it affects every part of our patients' lives. And the main thing is just for us to also, pretty rare, but also just to make sure it's not some weird cause of hyperhidrosis, like a secondary cause. 93% is just going to be a regular hyperhidrosis that we see, and we're really used to it. But there are other causes. There's other causes of hyperhidrosis in case you're having a fever, pregnancy, menopause. Of course, we see that as well. But we just want to make sure we're not missing something pathological, like lymphoma, infection, something else going on. These usually present a couple of things that present a little bit weird with secondary hyperhidrosis is if it's not symmetric. So usually we're used to seeing just our regular hyperhidrosis as craniofacial, axillary, palms, feet, very symmetric, usual places. Secondary hyperhidrosis could be asymmetric. That's a weird sign. It's there all the time, whether you're awake or you're asleep. They're just sweating all the time. That's abnormal, usually for just a regular hyperhidrosis. When you're sleeping at night, things are a little bit more calm. You don't really have the sweating. So just a couple of things to look out for. It doesn't happen often. But just things to kind of be aware of. Every once in a blue moon that can happen, so that we don't keep just giving them a regular treatments if they have something underlying. And then I'm going to mostly be talking about, as far as treatments, our topical antiperspirants, which is usually our first line that we all start with. We'll talk a little bit about ionophoresis, botulinum toxin, which I think still just works the best, and then oral agents, and just a little bit over the energy devices, because our patients ask about them. So even though we might not have them in the office, it's good to just have a little bit of knowledge about these options. The first one, the one we're most familiar with, aluminum chloride hexahydrate, brand naming Drysol, or there's others you can compound as well. That's probably what we usually start out with. And the main thing about this medication is that I know we probably know it like the back of our hands, but it is really important to set expectations, because I see a lot of patients that come and say it didn't work, they failed it. But if you look at the data, there's actually pretty good satisfaction rates with this if used properly, like 94% satisfaction rate axillary, 84% plantar, 60% palmar, which isn't always what we see at clinic. A lot of people come in and they're like, oh, it just didn't work for us. So it's important to kind of just set expectations with this. Make sure they know they're supposed to put on dry skin. It's supposed to be before bedtime. You don't just get up in the morning and put this on like a deodorant. It's like a true antiperspirant. It needs to have time to go in and block your the eccrine sweat gland ducts. And the most important thing is it takes 1 to 2 weeks to actually start working. So I think it's important for patients to know that. Otherwise, if they use it a few nights, they're still sweating a ton. Like, oh, this is just not working. So they have to give it a time before they start to see improvement. And then after that, once they kind of notice that, then they can see what interval they need to apply it to kind of keep that maintenance period. Irritation happens, but it only happens in about 21% of patients. I mean, that's a high enough number, but the large majority actually do not get irritated. So I feel like the large majority can use it. If used properly, it'll work. So this should be given a good try before we kind of go up to the next steps. If they are irritated, sometimes they just have to stop it, but you could try applying it less often. You could compound it with salicylic acid instead of alcohol. That helps in some patients. And then there's other patients that just, you've kind of lost them. They had a bad reaction and they don't want to put that on their skin again and be super itchy again, which is totally understandable. The last thing patients will ask you about this or any other antiperspirant over the counter are links to Alzheimer's disease and breast cancer. So that's, you'll see a lot of people scared of just aluminum. There's been a whole market of natural deodorants that have come out because of this fear. But really, these links are not really they haven't really held up with the science. The Alzheimer's link or that concern came up in the 60s when some brains of Alzheimer's patients were found to have increased aluminum in them. Hard to know why, but those further studies after that didn't really show that association. The breast cancer link is even less. Breast cancer, it sort of just was thought that, well, there's a lot of breast cancer happening in the upper outer quadrant of the breast. That's near the axilla. It's obviously from the deodorant or the antiperspirant. And time again, I think studies have shown that's not really true. It's out there. It's hard for some patients to convince them that it's fine to use aluminum. But the main thing is that aluminum is an antiperspirant, whereas deodorants, they just make you smell better. They're not going to stop your sweating. So they're really not an option for our patients with hyperhidrosis. As far as topicals, although this is a cloth, I'll just quickly go over glycopyrronium tosylate, brand name Qbrexza. And this you can use in patients 9 years and older. It's important to note that FDA indication is only for axillary hyperhidrosis, although some of us do use it for hands and feet. And then they're supposed to use the same cloth for both sides, so they don't just overdo the amount of medicine. But as long as they do those things correctly, it does have some effect. And the common adverse effects are like everything else with anticholinergic. So there's dry mouth. There is also irritation of skin that can happen, kind of similar to aluminum chloride, but it's a little bit less. It's about 17% for the erythema, about 14% from burning, stinging, but it's not zero as well. This can irritate the skin as well. This is from their phase 3 randomized trials, and you can see the gray line is vehicle or not getting any treatment or not having any active ingredient. And the orange line is active ingredient. And it does work. In about week 1, they start to see reduction in their sweat. And that seems to be still stable at about week 4. So it's an effective option. A lot of times hard to get covered by insurance. But some of my patients, I just tell them I'll prescribe it, see if we can get it. If not, I'm just going to warn them about that we may not be able to get it because of the cost. Other topical therapies, so over the counter, of course, there's lots of antiperspirants and deodorants out there. Aluminum zirconium trichlorohydrix is probably the least irritating. Vanicream has that, and some other brands, but you can have the patient just kind of look that up in case they have any irritation from the aluminum chloride that we've prescribed. That could be another one they could try. Topical botulinum toxin is something I'm really interested in. I'll just present a few slides after this on a study we did at UC Davis. The main problem with botulinum toxin is it works really, really well when we inject it, but it has a large molecular size. So it's really hard to actually get it to go through the skin. But there are some ways around that. So I'll go over that in a little bit. And then, of course, there's also topical anticholinergics that can be looked at. So this, I won't spend too much time on this, but this was a study we did at UC Davis. We basically wanted to see if we can use microneedles to create channels in your palms of your hands just to get botulinum toxin through. And spoiler alert, it was not amazing, or it didn't overpass injectable botulinum toxin, but we did prove the concept that you can get botulinum toxin where it needs to be using this method. Just a couple of slides on that. This is basically just talking about why we did it, because botulinum toxin works really well, but it's super painful, as you guys might have seen if you've tried to treat palmar hyperhidrosis. And we wanted to just see if we can do this painlessly. We used these microneedles. They were 500 micrometers, these roll-on microneedles. And the protocol was basically to use one hand with microneedle and then the other hand with fake microneedle. So you're not really poking any holes into the skin, and then put topical Botox on and botulinum toxin to see what happens. And then we did see in our studies the hand that did have the microneedle versus the one that didn't have the microneedle, the sweat production was actually decreased. So prove the concept that you can get botulinum toxin to get through even the thick skin on the palms. Again, it wasn't anywhere as good actually clinically as if we would have just injected the botulinum toxin. But it was an interesting thought. And this was the pain score, which was pretty minimal. It really didn't hurt patients at all. So I think that's just really interesting. Before we go on to oral agents, that's a really interesting area. I hope more is done with it. I think you can make the microneedles a little bit deeper. You can pick botulinum toxin that's a little bit smaller molecular size. But the main barrier for the botulinum toxin for the palms is the pain. So if we can surpass that, that's going to be a great treatment option. Oral agents, of course, we're familiar with, usually the anticholinergics. The main thing to be familiar with these treatments is when to avoid them. So they're at the very bottom there, we have some conditions and drugs to avoid them with, and contraindicated in things like myasthenia gravis, pyloric stenosis, but then also the relative contraindications, I think, are ones we forget about, like GI reflux. A lot of people have that, but just things for us to think about before we are prescribing these medications. Cardiac insufficiency, that could be seen in patients. So just when you see these things, glaucoma, I think, probably triggers more for most of us when we see that on the medication or the problem list. But things like reflux and cardiac insufficiency, just have that in the back of your mind too before prescribing these, as it may or may not have an effect on that. The most common ones, of course, the glycopyrrolate oxybutynin. I prescribe more glycopyrrolate to start with because it has limited ability to cross the lipid membrane, so it doesn't get into the brain, has fewer side effects for that purpose. Oxybutynin also works really well, but it does cross the lipid membrane, so that's the major difference between the two. And if patients have anxiety-triggered hyperhidrosis, you can consider beta blockers or benzodiazepines as well. The beta blockers, I usually just even send back to primary care for them to give their 2 cents on that before prescribing. Ionophoresis is another great option. She works really, really well for palmar and plantar, although there's lots of axillary devices now too with foam pads and different things for the underarms that work well. There are 4 main FDA approved ones. I think I just have 3 here. Dermadry is the 4th. That's not on here. But Dermadry, RA Fisher, Hydrix, they do require prescriptions, and they've made it pretty easy now. You can go onto their website and have like a little form and you fill out and you just email it or fax it back to them. So that's probably the easiest way to get that prescription over to them. Dry Ionic does not need a prescription actually, so you could just send patients to them. And that's a little bit easier. I think we all know we're familiar with ionophoresis devices. They basically just work by galvanic current transfer. So you stick your hands in the and the tap water. And then there's an anode that's in there that's positively charged. So the positive charge repels the positive hydrogen ions in the water. And those basically just get pushed into your sweat glands. So they basically clog the sweat glands, but they also can block some of the sympathetic nerve transmission as well. So it works actually pretty well, even though it's a simple system. Usually you would do it 3 to 4 times a week. Patients often ask that when we bring it up, because it's something I have to do every day for the rest of my life, because it's time consuming. But they usually just have to start 3 to 4 times a week, do it for about 20 to 30 minutes. And then once it starts kicking in, and you need to tell them as well, it will take 16 to 15 treatments to start seeing improvement. If again, it's not once or twice, and then they're going to see a whole lot. But once they start to get to that point, they can actually kind of back off and just figure out what the minimal amount is for them that they need to do to maintain the maintenance, which could be even like once a month for some patients. So it might not be that bad, or worse, like once a week. So it could be like a very viable option for some patients. It's effective in about 80%. Sometimes it can get a little worse before it gets better. Also important to tell people, our patients, that as well. Contraindications for it are pregnancy, metal implants, epilepsy. So just important to make sure they don't have any history of seizures, metal implants, IUDs before writing the prescription for it. With dry ionic, I suppose, if they're going to go straight to them, they don't need the prescription. But the ones you're writing the prescriptions for, that's the step where you can actually take a look at their medical history. And then side effect wise, it's pretty well tolerated. Sometimes they get these transient vesiculations, but it goes away. Sometimes that freaks patients out, but that does go away. Sometimes it can get a little bit red and dry, but usually it's pretty well tolerated. And then injectable botulinum toxin, I think we all know, just works really, really well. And it's just super painful in some areas. In the underarms, it's really not too bad. Everybody tolerates it really well. But when it gets to hands and the feet, I think are the worst. The 3 common formulations that can be used are the onabotulinum, which is, I think, what's mostly used. But you could also use the incobotulinum or avobotulinum in these areas as well. Side effect pain, of course, is the main thing. And then there are very strict contraindications, though. Like, you wouldn't want to use these in patients with myasthenia gravis or other neuropathies. So it's just important that we rule those out: pregnancy, lactation, all of that. There are some medications that can have contraindications to botulinum toxin, and have it written down here, like aminoglycosides, et cetera. But important just to make sure that we go over those interactions with patients as well. And this is injected usually in a dermal subcutaneous junction. It doesn't have to go super deep, but still enough that it does hurt for patients. And you do about 10 to 20 injections, and they're about 1 to 2 centimeters apart. And I've kind of tried it 1 versus 2, and I think it works about the same. So if you wanted to space them out a bit, but again, you have to get like if you're doing 50 units per hand, you have to get that 50 units. And so sometimes if you're doing every 2 centimeters, before you know it, you've gotten to the end and you have all this fluid left, and you have to go back to those areas. So you'll just get a hang of it. But if someone has a bigger palm, you could space it out a little bit more. Usually you would do about 50 to 100 units per axilla. For example, I usually just start with 50 in the axilla, 50 each, 50 on the palms each, 50 on the feet each, and only go up if you feel like the patient needs it, which is rare. Most people do pretty well with 50. Highest dose is to not exceed 400 and shouldn't exceed over 400 units over 4 months. So for just the very few patients where you might be going really high, just going to be aware of those numbers. And usually, hopefully 1 to 2 times annually, although there are some patients that do have to come in every 3 months. It does end up being a little bit more often. And then the pain in the palmar and plantar, the other part is just to warn them, it can last actually a couple of days. Sometimes the feet bruise a lot. So just things for patients to be worried about or know about, so they don't get really worried about it. Ways to reduce pain. I usually just use ice. There's all sorts of things you can do, but I usually just use ice because in the clinic setting, we just don't have a whole lot of time. For nerve blocks, it's a little bit riskier to do, just takes time. And we've noticed over time that these procedures are actually, unless you're just doing them cash-based, which most people don't, they're not reimbursed as well as you would think. So you sort of just want to get, you don't want to add a whole lot other things to it, I think. Otherwise, it just realistically, the clinic won't be able to sustain doing it for multiple patients. Side effects, there's temporary weakness that can happen. And in the hands, that can be a problem, especially for patients that use their hands quite a bit. Like, for example, like violin players or someone who's using intricate work. So other important things that you might want to just actually back off on the units and anything. Just find that balance of where their sweating is decreased, but they're still able to use their hands pretty well. these are just a couple of videos. I'll see if they play here. A little bit blurry. Sorry about that. But this is just, I'm injecting the palms of a patient. I've sped it up, but basically what you want to do is go really, really quickly. That's the key here. And then for her, she did come in an hour before. We did put some topical numbing. I don't know if that does much, but I think for her psychologically, it's helpful. And then we ice for a long time before we start injecting. So when she says like, I feel it, it's pretty cold now, then we start going. You want the ice to be at the point where you're going to go to next. So that's helpful to have as well. And as you can see, it bleeds a lot. And some of those areas, sometimes you get these like pinpoint areas of bruising, which can hurt for like a couple of days. Just also worried about that. So that's feet. Easy enough, the technique, but it's just really painful. So I think you feel really bad for patients. And the next video is the palm. The same thing, just this is sped up ×2. I'm not that fast, but it would be nice if you are that fast. The key here is just go as quickly as you can. Just get the hand. She again had some topical numbing for an hour. Not always necessary. So most of my patients I don't do that for. And then just a little bit of ice to have it cool down. And it's tolerable. Not pleasant, but doable and tolerable.
The same.
Perfect. So just very quick about devices. There's a couple. The main one I think most people have heard about is miradry. They might ask you about it. It does work pretty well. It's FDA approved for axillary hyperhidrosis. I'll move this up a bit. But it's basically irreversible thermolysis. So you're actually destroying the eccrine sweat glands. And if you can do that, it's actually the efficacy is about 90%. It works pretty well over 12 months. But the main side effect that kind of scares everybody about this, it's pretty rare, but you could in theory damage the brachial plexus. So that's one that patients sometimes, that's like the deal breaker, but otherwise it's pretty well tolerated. They did actually recently have some bad publicity, but it didn't have anything to do really with miradry. There was this influencer bodybuilder. She was having this procedure done in Mexico, and they had put her under general anesthesia, which is really unnecessary. Actually, for miradry, you can just do topical anesthesia. And I think she passed away from the very sad story, but she passed away from the general anesthesia more than anything. But just so feel bad for miradry. There's a little bit of negative news for them there. But other than that, it's really safe. So it's not likely to cause anything like that. That was, I think, it's just a fluke, just in case a patient asks you about that. Other things that I don't think are used as often, but there's ultrasound therapy like all therapy or other devices. Fractional microneedle radio frequency can be tried as well. And then I think less good results with an Nd:YAG or PDL, but there are some studies on those lasers as well.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.